All right, this is Dr. Anju Singh, and I'm just recording the vision component of special senses chapter. So vision is our sense of sight, where we are able to perceive objects from our environment by means of light that they emit or reflect. Light is a narrow spectrum of wavelength of the electromagnetic radiation that we get from the sun. So we get a very wide range of electromagnetic radiation from the sun, but a very narrow spectrum of that between 400 and 700 nanometers is a stimulus for the photoreceptors of our eyes, and therefore that gives us the sense of vision. And so we're able to see those electromagnetic radiation, and that's what makes up light. And light must cause a photochemical reaction to produce the nerve signal. So just like all the other receptors we've seen so far, receptors are transducers, so they convert a form of energy into nerve impulses. Like mechanoreceptors will convert mechanical energy into nerve impulses, and chemical chemoreceptors will convert chemical energy into nerve impulses. So here we have receptors that will convert photo or your electromagnetic radiation into nerve impulses. In this spectrum, anything less than 400 nanometers is considered ultraviolet radiation. It has way too much energy, and it actually can destroy macromolecules. So ultraviolet is not good for us. Ultraviolet radiation causes DNA damage, increases our risk for skin cancer. Infrared radiation is the opposite end of the spectrum, where the wavelength is more than 700 nanometers, and that does not have enough energy to cause photochemical reactions, and it does not harm us, and it is actually used clinically for certain kind of injuries because it makes the tissue warm. So infrared radiation is actually used for sprains and certain other injuries. Looking at the anatomy of the eye, we have eyebrows sort of along the supraorbital ridge. The hair of the eyebrows protect the eye from sweat and dust and debris falling into the eye. The gap in the skin on the face, which allows for the eyeball to be able to, perceive eye, the gap is known as the palpebral fissure. The medial end of the palpebral fissure becomes the medial commissure, and the lateral end is a lateral commissure. So the upper fold is the upper eyelid or the superior palpebra, and the inferior fold is the inferior palpebra. The folds on the upper eyelid is then known as the superior palpebral sulcus and the inferior palpebral sulcus. The margin of the eyelid becomes the tarsal plate, and the margins are a little bit tougher. They're not as soft as the rest of the skin. They have a little more dense connective tissue, and the opening of the tarsal glands are along the tarsal plate. And on the edge of the tarsal plate, we have eyelashes. So we have the upper eyelashes and the lower eyelashes. And they too do the function of protecting the eye from any dust and debris and foreign material or insects going into the eye. The white part of the eye is known as the sclera. It is covered by the conjunctiva, which has the blood vessels. The conjunctiva is transparent, but the conjunctiva does not go past the corneoscleral junction. The clear part of the eye is known as the cornea, and behind that and through that is what we see as the colored part of the eye, which is known as the iris. The gap in the iris is known as the pupil. So that's most of the external anatomy of the orbital region. So the orbital region of the face is that area around the eye socket or the orbit. The eyebrows also help with enhancing facial expression. They protect the eye from glare and perspiration. The eyelids, also known as the palpebrae, they block foreign objects, help with sleep, and the blink reflex. Blink reflex is not only protective, but also spreads the tears that are produced by the lacrimal gland, spreads it all over the eye, keeping the eye moist, which is critical for vision. The eyelids meet at the corners of the commissures, and they consist of orbicularis oculi, which is a round muscle that goes around the eye and helps us shut our eyes tight. But we also have the levator palpebris superioris muscle there, and the tarsal plate that covers the skin outside, and the conjunctiva on the inside. The tarsal glands secrete oil that reduces your tear evaporation, and eyelashes that help keep the eye, keep debris from the eye. Conjunctiva, as I said, is a transparent mucous membrane. It lines the eyelid, covers the anterior eyeball, but does not cover the cornea. In certain conditions, like people who work in dry, dusty environments, for example, farmers, if they exposed long-term exposure to dry, dusty environments can actually stimulate the conjunctiva to grow onto the cornea. That condition is known as pterygium, and it can actually impair vision. So that is not normal. The conjunctiva is richly innervated and vascular, and therefore it heals quickly. So any conjunctival injuries, as long as they're not infected or otherwise complicated because of some other condition, they usually heal really quickly. The conjunctiva secretes a very thin mucus film, again, to prevent the eyeball from drying. Behind the eye, there is orbital fat that cushions the eye in the orbit and protects the vessels and nerves of the orbit. The lacrimal apparatus is the apparatus that makes, distributes, and drains the tears. The tears, they wash and lubricate the eye, they deliver oxygen and nutrients and prevent infection with the bactericidal lysosome. So the cornea is avascular. There are no blood vessels in the cornea because blood is opaque. So having any blood vessels in the cornea would actually impair vision. So the cornea has 5 layers to it. The cornea depends on diffusion of oxygen and nutrients. The superficial surfaces depend on the tears and the air to get their nutrient, and the deeper layers of the cornea depend on the aqueous humor, which comes from the anterior chamber, to get their nutritional needs met. The tears, after covering the eye and washing out any debris and protecting from any bacterial infection, flow into the lacrimal puncta. There's a little openings, both one on the upper eyelid, one on the lower eyelid. And through these puncta, they go into canaliculi and ultimately drain into the lacrimal sac. And from the lacrimal sac, which sits on the lacrimal fossa, on the lacrimal bone, finally drains through the nasolacrimal duct into the nasal cavity. So in this figure here, we're seeing sort of a parasagittal section model of the eye. And on the right, we're seeing the lacrimal apparatus. So the lacrimal gland is superolateral, and the orbit produces tears. And through many small ducts, those tears come into the conjunctival sac. And by blinking motion, they are spread all over the eye and finally drain out through the puncta. There's one puncta on the lower eyelid and one puncta on the upper eyelid, through the canaliculi into the lacrimal sac and down into the nasal cavity, through the inferior nasal meatus in the nasal cavity. Extrinsic muscles of the eye. Again, we have 6 extrinsic muscles. We did touch upon them briefly when we did muscles. These are skeletal muscles. They are under our voluntary control. Superior, inferior, medial, and lateral rectus muscles. And then we have a superior and inferior oblique muscle. Most of these muscles get their innervation from the 3rd nerve, but we have, as I say, the SO4 and LR6. So superior oblique gets its innervation from the 4th cranial nerve and lateral rectus from the 6th cranial nerve. The superior, inferior, medial, and lateral rectus muscles move the eye up, down, medially, and laterally, respectively, whereas the superior oblique and inferior oblique not only move the eye up and down, but they also move the 12 o'clock position of the eye. So again, looking at the muscles on a lateral view, the muscles all originate from a tendinous cone at the tip of the orbit and innervate. If you notice the insertion of these muscles is equidistant. Innervation of the recti muscle, the superior rectus, inferior rectus, medial, and lateral rectus. Their distance from the corneoscleral segment, corneoscleral junction, is practically the same. And therefore, their action will be elevation, depression, lateral abduction, or adduction. Whereas the oblique muscles not only go obliquely, but their insertion is a little bit posterior to the ring of the recti muscles. And therefore, when they contract, when the superior oblique muscle contract, it moves the 12 o'clock position medially and the eyeball a little bit inferiorly. Whereas the inferior oblique muscle, when it contracts, it moves the 12 o'clock position laterally and also elevates the eye. Again, looking at the anatomy of the eyeball itself, the eyeball has three coats. The outer fibrous, strong, thick coat is known as the sclera. The sclera continues anteriorly as the transparent cornea. The second layer is heavily pigmented and very vascular. That's known as the choroid. The choroid continues anteriorly as the ciliary body, which has the ciliary muscles, the ciliary processes, and that continues anteriorly as the iris. All of this is sometimes collectively also known as the uvea. So inflammation of just this area is known as uveitis. But again, if there's inflammation of the choroid, sometimes it's called choroiditis. Sometimes it's inflammation just of the iris and it's called iritis. So again, you get slightly different variations of inflammation in this tissue. The innermost layer of the eye is the neural layer known as the retina. That's the layer that has the photoreceptors that help us see. The central part of the retina, the part that fixes. So if you are reading, say, for example, if you're looking at figure 16.26 and your vision is focused on the dot, the decimal point, the image of that dot is falling on the fovea, right? So that's the point of fixation. It has the highest visual acuity, right? The highest ability to discriminate between two small points. As you move away from the fovea, our visual acuity starts decreasing. And you'll also notice the fovea is the thinnest part of the retina, again, to increase visual acuity. And we'll get to that in a little bit, why this is the thinnest part. And therefore, compensatory, just around the fovea centralis, the retina is actually thicker. And then as it spreads peripherally, it gets thinner and finally ends in the ora serrata. So the retina does not extend into the anterior part of the eye. It ends at the ora serrata. The nerve fibers of the ganglion cell leave the eyeball as the optic nerve. And so this region where the optic nerve is leaving the eyeball, there are no photoreceptors here. So this makes up the blind spot of the eye and is also known as the optic disc when doing fundoscopy or looking at the retina. Anteriorly, again, the anteriormost clear layer is the cornea. Just behind that, the chamber filled with aqueous humor is known as the anterior chamber. The aqueous humor is made by the ciliary processes in the posterior chamber. So aqueous humor, it's produced in the posterior chamber, goes through the pupil into the anterior chamber, and then finally is drained out through the canal of Schlemm, which is usually right here at the corneoscleral junction. Behind the iris, there are zonules that extend from the ciliary body, and they suspend the lens. The lens itself is covered by a capsule and has many, many layers of fibers in it. So when the ciliary muscles contract, they actually decrease the diameter, make the zonules loose, and therefore allow the curvature of the lens to increase, which is required for focusing. When the ciliary muscles relax, it increases the diameter, it pulls these zonules and straightens the lens, if you will, makes the curvature less, which is required for distant vision. And we'll see that a little later in this chapter. The eye also receives blood supply from the central retinal artery and drains out, the venous blood drains out through the central retinal vein. The choroid also is richly vascular, so the outer layers of the retina get their nutrition from the choroid, and the inner layers of the retina get their nutrition from these blood vessels. The macula, the central region of the eye, of the retina, is known as the macula. The macula is avascular, again, because it has to remain transparent, as the presence of blood cells in front of it would make it opaque. Behind the lens, the posterior part of the eyeball is filled with the vitreous body, which is a thicker gelatinous substance, which gives the eyeball its shape and helps keep the retina attached to the choroid. In certain conditions like pathological myopia, and sometimes even in elderly people, this gelatinous structure loses its gel-like composition and becomes fluid, in which case the patients may be at higher risk of retinal detachment. The retina does not stay attached to the choroid and actually separates and floats freely in this fluid chamber, but because it no longer gets its nutrition from the choroid, it actually undergoes ischemic damage and the person can become blind. So the tunics, the outermost is the sclera, which is transparent anteriorly, known as the cornea. Then your tunica vasculosa, that's your uvea or the choroid, very, very vascular and heavily pigmented. And anteriorly, that's known as the ciliary body, which has the ciliary processes, the ciliary muscle, and then continues anteriorly as the iris. Iris is that colored diaphragm, and it has circular muscles and radial muscles that control the size of the pupil. People with dark eyes, they have a lot of melanin or chromatophores, and depending on the amount of as the amount of melanin decreases, you get different shades of color. So people with blue eyes, green eyes, gray eyes, they just have lesser amount of melanin in them. And the innermost layer of the eye is the retina. The optic components, again, the transparent elements that allow light to go in. So it is important for you to know the path of light. So light comes in through the cornea, goes through the aqueous humor, goes through the lens, goes through the vitreous body, goes through all the layers of the retina, we'll see in a little bit, before it can stimulate the photoreceptors. The cornea, as I said, is transparent anteriorly. The aqueous humor is the serous fluid that is secreted by the ciliary body into the posterior chamber, posterior to the cornea, and it is anterior to the lens. The vitreous aqueous humor does not go behind the lens. Behind the lens is all the gelatinous vitreous humor. And vitreous humor, after flowing out into the anterior chamber, comes out to the angle. So the angle between the iris and the cornea is known as the angle of the eye. And in that angle is where we have the scleral venous sinuses. And the aqueous humor is absorbed at the same rate as it is secreted. And that's how intraocular pressure is maintained. If the aqueous humor is not able to drain out, which can happen sometimes as a result of injury or as a result of inflammation, or because some people, their angle is very narrow and the iris crowds at the angle and physically blocks the aqueous humor from flowing out. All of those conditions can result in increased intraocular pressure. And if that happens in an acute manner, it's an extremely painful acute glaucomatic attack. But in some patients, it can be asymptomatic and chronic. And therefore, regular eye examinations and measuring the intraocular pressure and examining the angle, looking to make sure it is functioning normally, is important. The lens, again, changes in the shape of the lens help focus the eye. Now remember, most of the refraction of light for vision is done at the cornea. So 80% of refraction of light is done at the cornea. Only the remaining 20% or so is done by the lens. So lens really just helps us focus and is therefore plays a more critical role in near vision. In case of, say, cataract, when the lens is removed, and if an intraocular lens is not put there to replace the natural lens, the patient still has what we call ambulatory vision. The patient is no longer blind. So when there is a cataract occluding the path of light, the patient can be legally blind if it is a mature cataract. And just removal of the lens will give the patient aphakic vision, where the patient is at least ambulatory. They're able to function relatively reasonably. They may not be able to read the newspaper, right? So that's the important part of the lens. It helps focus the light. It is suspended by these suspensory ligaments. Some books call them zonules from the ciliary body, and it is rounded when there is no tension. And there is no tension on these zonules when the ciliary muscles contract and they decrease the diameter. It is flattened when it is pulled by the suspensory ligaments. So when the ciliary muscles are relaxed, the zonules are pulled and the lens is flattened, which is what we need for distant vision. Vitreous humor is the jelly-like substance. It fills the vitreous chamber. It is a space behind the lens, from the lens up to the retina. Right, so this is showing you the production and flow of aqueous humor. So it is produced by the ciliary processes, goes through the pupil into the anterior chamber, and flows out through the scleral venous sinuses. And some books call them the canal of Schlemm. And this would be the angle of the eye, right? This angle between the cornea and the iris. So some people have a narrow angle. A narrow angle means this angle is really narrow. So these people are at higher risk of having glaucoma. So for example, if the pupil dilates, so sometimes when we go to the doctor's office and we need to get a fundoscopy done, that means the doctor needs to go look at the retina. Often they would like to get the iris out of the way by dilating the pupil so they can get good access and look at the retina up to the ora serrata. But when the iris dilates, when the pupil dilates, the iris collects at the angle. So people who have a narrow angle are then at a high risk of having acute glaucoma attack in response to dilatation of the pupil. And so usually this angle is evaluated before a patient's pupil is dilated. This is showing you a high magnified view of the lens, and these are the zonules. And over here, what we are seeing, this line, that is the anterior capsule that has been opened, and part of it has been removed. We can still see small parts of the anterior capsule. And this looks like this has been done on, like this is how a cataract surgery is done. The anterior capsule is removed, and then the lens is scooped out. The posterior capsule, which lies below and behind these zonules, is supposed to be left intact because that's what keeps the vitreous humor in the posterior chamber. If the posterior capsule gets damaged during a cataract surgery, that is actually considered a complication of a cataract surgery. So cataracts and glaucoma. Cataract is when the lens gets cloudy, right? And there are many, many different types of cataracts. So congenital cataract is when the child is born with a cataract. Traumatic cataract is when the lens becomes opaque as a result of trauma. Many diseases can cause cataract too. The most common kind of cataract is senile cataract, age-related, and that too can be nuclear or peripheral, right? So if the center of the lens starts getting opaque first, that's a nuclear cataract. If the periphery of the lens starts getting opaque first, that's a peripheral cataract. And again, I don't want to go into too much details on that, but doing cataract surgery and all that, that's a whole different field of surgery pursued by ophthalmologists. So the lens fibers darken with age. So lens fibers technically are similar to stratified squamous epithelium. The lens capsule makes those fibers, and the fibers are pushed towards the nucleus with time. So the fibers that were there at birth are still there when we age. And there's an inverted Y-shaped nucleus in the center of the lens. So these fibers tend to darken with age, again, because the capsule tends to lose its integrity, sort of wears out and allows fluid to seep into the lens. So normal healthy lens is absolutely dry. There's no fluid inside the lens itself. But if fluid fills inside, then that can disrupt vision. So there can be fluid-filled bubbles and clefts filled with debris that appear between the fibers. Cataract can also be induced by diabetes, by smoking, as a result of certain drugs, by ultraviolet radiation, and by certain viruses. So there's a long list of things that can cause cataract. It is usually treated by replacing the natural lens with a plastic one. Glaucoma is a condition where the intraocular pressure in the eye increases due to the obstruction of flow of aqueous humor out of the scleral venous sinuses, right? So the drainage of aqueous humor is not proper. And intraocular pressure is usually monitored or measured by a tonometer. When the pressure rises, the blood supply to the retina is compromised. And if this occurs long enough, then the retinal tissue undergoes ischemic damage. So there's death of the retinal cells due to compression of the blood vessels and lack of oxygen to the retina. And ultimately, the blindness is permanent. Early symptoms, patients may complain of illusionary flashes. Flashes of light is a sort of a red alert, if you will, when a patient complains of flashes of light. Not only just for glaucoma, but even patients with very high myopia can complain of flashes of light, which is an indicator that the retina may be separating. There could be retinal holes in the periphery of the retina, and the retina is at risk of separating. Patients may see colored halos around lights. which is a later symptom. And again, this is because of damage to the retina. Once the retina is damaged and vision is lost, that loss is permanent. So loss of vision as a result of glaucoma cannot be restored. Unlike cataract, where you can remove the lens and you can replace it with an intraocular plastic lens, and vision is restored, retinal damage due to glaucoma is permanent. Right, so that's just showing you a patient where you can see the opaque cataract through the pupil. And in glaucoma, the peripheral part of the retina gets damaged first. And as it progresses, then the central part gets damaged. So patient gets what's known as tunnel vision, which is the opposite of the kind of visual field defect seen with macular degeneration. Right? So patients with glaucoma, if a patient has asymptomatic chronic glaucoma, so the patient is not presenting with severe pain and redness in the eye. Acute glaucoma is easier to diagnose because the patient will present with severe pain and redness of the eye, and they will show up in the ER and you do a tonometry and you see that the eye pressure is high and it can be treated. But asymptomatic chronic glaucoma patient has no pain, patient has no way of knowing that they have glaucoma if they're not going to the doctor for regular examination. And what happens in those patients is that slowly the periphery of the retina starts degenerating and getting destroyed. And by the time the patients present in clinic, they usually present saying that they keep bumping into things. They very rarely are aware that they have tunnel vision. If they are aware, that is in itself a sign of pretty advanced glaucoma. So they usually present saying, I keep bumping into stuff, or, it's like I don't see things that are in my periphery because their peripheral vision is compromised. So the neural components of the eye, that's your retina, right? The retina is from the outgrowth of the diencephalon, or the optic vesicle. It is attached to the eye at the optic disc. That is the posterior exit of the optic nerve, and at the ora serrata anteriorly, that's the anterior edge of the retina. It is pressed up against the rear of the eyeball by the vitreous humor, right? So if the vitreous humor is compromised and loses its structure, the retina will fall off, will get detached. So detached retina causes blurry area of vision and blindness. So when a patient has a retinal detachment is not a slow, insidious, asymptomatic process. Once retinal detachment starts, once, like, say, the fluid vitreous humor goes behind the retina, it quickly fills in and separates the whole retina from the choroid. And the patient says that they felt as if a dark curtain fell in front of one eye, and now they can't see out of that eye. So it's a very dramatic, usually pretty fast onset. And retinal detachment surgery can be done. If done in a timely manner, vision can be restored. Perhaps not as good as it was before, but if the retina stays detached long enough to undergo ischemic damage, then that loss of vision is permanent. So retina is examined clinically by an ophthalmoscope to show the fundus, or the rear of the eye. And so that procedure is also known as fundoscopy. During a fundoscopy, what the doctor is looking at the macula. How does the macula look? So the macula is a central part of the eye, patch of cells in the visual axis of the eye. And this has, a majority of your cones, your color vision. It has good visual acuity. Fovea centralis is right in the center, the pit in the center of the macula lutea. So that is the part that has the highest visual acuity. And then we also look at blood vessels of the retina to make sure everything is good. So for example, diabetic patients, hypertensive patients will start seeing some abnormalities in the retina and in the blood vessel. So this is showing a physician doing a fundoscopy on this child, and this is what they see through the fundoscope. So the pale area, the pale round area, that's the optic disc. That's where the fibers of the ganglionic cells are leaving the eye. This is also where the central retinal artery enters the eye, central retinal vein leaves the eye. And these are all branches of the central retinal artery and vein. There are two superior and inferior temporal branches, superior and inferior nasal branches. And this central part, that's the macula, and you can see the macula is avascular. There are no blood vessels here. This dark area and the blood vessels that we're seeing here, we're seeing through the retina. Retina is a transparent tissue. We're seeing through the retina. We're looking at the retinal pigment epithelium and the choroid behind the retina. That's what we're seeing over here. So That's all the choroid seen posteriorly. This is a model of the fundus, again showing the optic disc, the blood vessels, the macula, and the fovea centralis. Retinal circulation is end arterial circulation. So there is no anastomosis, there's no backup blood supply. So if a patient has a central retinal artery occlusion, the entire eye goes blind. There is no backup blood supply to the eye. This is a neat test to see your own or perceive your own blind spot. There are no receptors where the optic disc is, because that's where the fibers turn around and leave the eye. But the brain, we are not consciously aware or conscious of our blind spot, because the brain fills in that area with whatever is around that area. And you can see that. So if you close your right eye, you have to adjust your distance from the screen. But if you close your right eye and stare at the X, while staring at the X, you will notice that the red dot disappears, right? Because the red dot now falls on your blind spot. And technically that the blind spot lies along the 15 degrees temporal from your line of fixation. So when you're looking at the X, the line drawn from your eye to the X would be your 0 degrees. So if you go 15 degrees temporal, that's where your blind spot would be. And you can even switch it around, close your left eye, now look at the red spot with your right eye, the X will disappear because now the X falls on your blind spot. And what you do notice is that the green line just seems to continue. So the green line fills in that space where the red dot and the X were. So formation of the image, light passes through the lens to form a tiny inverted image on the retina. So the image we see on the retina is a real and inverted image. It's not a virtual image. The iris diaphragm, the diameter of the iris, is controlled by two sets of contractile elements. We have pupillary constrictors. These are your round, smooth muscles. They are innervated by the parasympathetic nerves, and parasympathetic stimulation will narrow the pupil. So remember, we need pupillary constriction for reading. Parasympathetic is for reading. And pupillary dilators are innervated by sympathetic nerves. So sympathetic stimulation widens the pupil, and we need wider pupils for distant vision. Pupillary constriction and dilatation occurs when the light intensity changes or when the gaze shifts, right, from distance to nearby. So pupil constrict when we look near. They dilate when we look far away. Pupil constrict when the light intensity increases, and pupil dilate when the light intensity decreases. So your photopupillary reflex, this is your pupillary reflex, your response to the pupil, response of the pupil to intensity of light. So pupillary constriction and response to light. The important part about that is that even if one eye is stimulated with light, both the pupil will respond, because remember, the autonomic innervation is more diffuse and is bilateral. There is a virtual lab on this. I would encourage you to spend a few minutes doing that lab. It's not a very long lab. And how this is tested clinically is you sit in a relatively dark room, and a flashlight is shone on one eye from the side, not directly into the pupil, but just on one side, more to prevent the light going into the other eye. So say we shine light on the periphery of the right eye, we look at the pupil of both the eyes, and we'll see both the pupil will contract simultaneously and equally. So it is a bilateral reflex. So it is an autonomic reflex arc. The brighter light is signaled to the pretectal region in the midbrain. It excites your parasympathetic fibers in the oculomotor nerve that travel through the ciliary ganglion into the orbit, and your postganglionic parasympathetic fibers will stimulate your pupillary constrictor muscles, thus constricting the pupil. And it is bilateral. So stimulating one eye will result in bilateral pupillary constriction. Refraction is the phenomena of light bending as it travels from one medium to another, because the density of the medium changes, right? So air is not as dense as corneal tissue or as aqueous humor. So that bending of light is called as refraction, and the amount of how much the light bends, or how much the density of the ability of a media to bend light is called its refractive index. So refractive index of a media can be is a measure of how much a substance retards the light rays. So light will travel a little bit slower and at a slightly different path once it enters a more dense media. The speed of light is about 300,000 kilometers per second in vacuum, but it is slower in air, and it gets even slower in water and glass. And then as the media gets thicker, and that's what makes media more opaque. So very, very dense media becomes very opaque. The greater the difference between the refractive indices between the two media, the more strongly the light rays will refract when passing from one to the other. Remember, and refraction, the light is still passing through them. So you see refraction in media that are transparent. There is no refraction happening in opaque media. Angle of incidence is the angle between the light ray at which the light strikes the surface. So at 90 degrees, the light slows down but does not change its course. So it continues straight. At any other angle, light rays will change their direction. So for example, this is a transparent, dense object. Light is traveling through air, but as long as it's coming directly at 90 degrees with the object, it will continue in the same course. It does not bend. However, if there is an angle, then the light bends, and usually laws of refraction, it'll bend towards the normal. So the normal is in 90 degrees. So this light is bending towards the normal. And then when it goes from this media back into air, it bends away from the normal. So this ray, the incident ray, is parallel to the refractory ray, but it's not on the same path. It moved. And so this phenomenon is known as refraction. So cornea refracts light more than the lens does, because corneal tissue is a little more dense than lens tissue. Light passes through the center of the cornea. The light that passes through the center of the cornea is not bent because it is at 90 degrees. Light strikes off the center and is bent towards the center. Aqueous humor and lens do not greatly alter the path of light. Lens merely fine-tunes the image. The lens becomes rounder to increase the refraction for near vision. And we'll see that in a minute, how that works. So emetropia is your normal vision in majority of the people is called emetropia. So that's 20/20 vision, which means we can see our 2-point discrimination at 20 feet is the same as it is for most other people. So at 20 feet, I see what everybody else sees as 20 feet. So my vision would be 20/20. If it's say 2200, that means I am seeing from 20 feet what anybody else can see from 200 feet. And that is sort of usually the line at legal blindness. If an eye has 2200 vision, it's considered to be legally blind. So light rays coming from that object are essentially parallel. The rays will be focused on the retina without any effort. So that's to get a nice clear vision. The rays or the image of the object must fall on the retina. If it falls in front of the retina or behind the retina, we get a very blurry image. We don't get a clear image. Light rays coming from a closer object are too divergent to be focused to fall on the retina, and therefore the lens is required to focus it and move the image so that it falls exactly on the retina. So that adjustment to the close range vision requires 3 basic processes. One is convergence. So when we're looking at distant objects, the movement of eyes, they move parallel to each other. So when we turn our gaze to the right, our right eye abducts and our left eye adducts, right? And vice versa. When we move our eyes to the left, our left eye abducts and our right eye adducts. So the two eyes are moving parallel to each other. But when we try to look at something close by, if you try to look at the tip of your nose, both your eyes are adducting, right? So now they are not moving parallel to each other. That movement is called convergence. The eyes orient their visual axis towards the object, and they are not parallel to each other anymore. So that's called convergence of the eye. Constriction of the pupil is another part of your near response. And what this does is it blocks all the peripheral light coming in and reduces any spherical aberration. That means light that's coming in from the spherical part, the peripheral part of the cornea, it refracts a little more, and so can make the image a little blurry. When it comes in through the center of the cornea, it doesn't refract as much, it stays on its path, right? So that's spherical aberration. And it's not just light, it is also spherical aberration includes chromatic aberration. As light refracts, it separates into all its different colors, right? So not only does it become blurry, it can also cause rainbows. It can cause that glare effect, if you will. So to reduce all that, constriction is required. And then finally, accommodation of the lens. This is where the lens changes its curvature. So the ciliary muscles contract. Remember, ciliary muscles are all around the eye. So when they contract, they decrease the diameter of the eye, if you will, or the circumference, if you will, of the eye. And that makes the zonules loose. They slacken the zonule. When the zonules become loose, the lens becomes thicker. And as the convexity of the lens increases, the focus point of the lens decreases. The focus point would be the center of the circle. If the curvature of the lens was to be continued to make a full circle, where would the center of that circle be? So as the lens becomes more curved, that center comes closer. As the lens becomes flatter, the curve is less. That means the circle gets bigger, so its center gets further away, right? So that's your focal point. So the focal point comes closer as the lens becomes more curved, if you will. So light is refracted more strongly and focused onto the retina. The near point of vision, this is the closest an object can be and still come into focus within, still be seen clearly. So again, if you want to test your own, there is a virtual lab on that too, where you take a object and you start bringing it closer and closer and closer. You will see that for quite a distance, you will still be able to see that object or any print written on it pretty clearly. But at some point, if it gets too close to your eyes, it'll start getting blurry again. So the last point or the closest point at which you were able to read that fine print clearly, that is your close point, right? Near point of vision. As we age, these suspensory ligaments become stiff and they lose their ability to be able to change the curvature of the lens. And so what that does, it moves the near point further and further away, because the whole point of increasing the curvature of the lens was to bring that focal point closer. But with age, as the zonules become stiff, they're not able to bring the focal point closer, and therefore our near point recedes. And that condition, it's physiological, it is age-related, and that's known as presbyopia. So in an emmetropic normal person eye, when they look at distant objects, the rays of light coming in are practically parallel to each other. However, when we try to read a near object, the rays of light coming are divergent, and the eyes must converge in order to form that image on the retina. So near response, one component is convergence. The second component is pupillary constriction. Again, making it like a pinpoint pinhole vision. And the lens accommodation, the lens which was relatively flat becomes more curved. So accommodation of the lens is again showing when the pupillary muscles are relaxed, the zonules are taut, and the lens is thinner. And when the pupillary muscles contract, they loosen or slacken the suspensory ligaments, which allows the lens to bulge out. So the lens thickens, which brings the near point closer. So clinically, what happens if people are not emmetropic? Two conditions that can occur is, number one, they can be hyperopic, hyperopia, also known as farsighted. In these people, the eyeball is short. So the image of the object falls behind the retina. This is commonly seen in young children, and they can grow out of this condition. As they grow, the eyeball can elongate and come to emmetropia. So little children more commonly tend to have hyperopia, and they can grow out of this condition. In order to correct this condition, a convex lens is put, and depending on the strength of this lens, is adjusted to make sure that the image falls sharply on the retina. The other condition is myopia, also known as nearsightedness. Here, the eyeball is too long. And so this condition tends to occur more frequently in growing children. So this is the condition you'll start first seeing, in middle school or high school kids. And once they stop growing, the myopia will not progress anymore. But again, you can have pathological myopia that the eyeball continues to grow, and it can really, there are many other conditions. But again, most commonly is mild to moderate myopia, where the eyeball is a little too long and the image falls in front of the retina. And this is corrected by a concave lens. And again, the power of the lens is adjusted such that the image falls sharply on the retina. And remember, presbyopia is a whole different condition. It is technically a kind of hyperopia where you have your near point recedes. So now coming to the sensory transduction of the retina. The retina is made up of many different layers. The outermost layer, or the posteriormost layer, the layer that is closest to the choroid, that is your retinal pigment epithelium. The pigment is required because after light has passed through all the layers of the retina, it must get absorbed. Otherwise, the retina is a nice, clean, clear, transparent neural tissue. It will make the light bounce around inside the eyeball, which will cause multiple images and a lot of glare, and we will not have any visual acuity, right? We won't have good vision. So light must pass through all the layers of the retina and get absorbed so that it only stimulates the photoreceptors in its path. So that's the job of the retinal pigment epithelium. It absorbs any stray light, so the visual image is not degraded. The rest of the retina is known as the neural component of the retina. So this is not nervous tissue. This is just pigment tissue. The rest of the layers of the retina are the neural components. When the retina does detach, so for example, in high myopia, where the eyeball is so elongated, let me go back to the myopia. If the eyeball is really, really elongated, the retina near the ora serrata gets stretched and thinned, can get retinal holes, and the vitreous humor becomes liquid and leaks through these holes and separates the retina from the choroid. That's how retinal detachment works. It always stays attached at the optic disc, right? Because the optic disc is just the fibers of these cells, the axons of the ganglionic cells. And the layer at which this retinal detachment takes place is between the pigment epithelium and the rest of the neural retina. The pigment epithelium, which is anatomically part of the retina, stays attached to the choroid, and the rest of the neural retina is what gets detached, right? The neural component, the outermost layer, the layer closest to the choroid after the pigment epithelium, is your photoreceptor layer. So that's the layer that has your photoreceptors. We have two types of photoreceptors, rods and cones, and they are named rods and cones because of the shape of their outer segment. So these are the ones they can get stimulated by light, and they can convert that light energy into a electrical signal, into a nerve action potential. So only rods and cones produce visual images. We have many other cells in the neural component of the retina, but your photoreceptors, the ones that are responsible for vision, are your rods and cones. The other kind of cells are your bipolar cells. Again, remember, we saw classification of neurons, pseudo-unipolar, bipolar, and multipolar. We saw pseudo-unipolar cells in a posterior root ganglion, in our sensory cells. And all interneurons, all motor neurons are all multipolar neurons. We have not seen bipolar neurons up until we started doing special senses. Special senses are the only ones that have bipolar neurons. The bipolar neurons are the first order neurons in the retina, and they synapse on one side with the rods and cones, and they carry the signal to the ganglion cells, which are on the other sides. The ganglion cells are your second order neurons. This is the only part of the body where we see second order neurons outside of the central nervous system, so to speak. Another way to rephrase that would be, this is the only place where the central nervous system is visible to us, right? The olfactory nerve, the first cranial nerve, is the only part of the central nervous system that is exposed to the outside, to the nasal mucosa. And the ganglion cells, the second order neuron, this is the only place in the body where the second order neurons are visible to us physiologically, right? So the ganglionic cells, these are second order neurons, these are the axons that the axons of these cells finally form the optic nerve. So looking at the histology of the eye, of the retina, this would be where the front of the eye would be. This is the vitreous humor. So light comes in from here, the cornea, the lens, all of that is up here in the front of the eye. Light passes through all of that structures, comes through the vitreous humor, goes through all the layers of the retina, and finally gets absorbed by the pigment epithelium. Behind the pigment epithelium is the choroid, and outermost layer is the sclera. So this is the outermost layer of the eye at the back of the eye. Then is the choroid. This is the first layer of the retina. In retinal detachment, separation takes place between this and the rest of the layers. So this is your layer of your photoreceptors. These are the outer segments of the photoreceptors, and these will be the nuclei of the photoreceptors. So all this entire layer is the layer of photoreceptors. This is the layer of plexus or synapses between the receptors and the bipolar cells. Bipolar cells, one pole towards the receptors and one pole towards the ganglionic cells. This layer here is the plexus between the bipolar cells and the ganglionic cells. And then your ganglionic cells, your second order neurons, the axons of these are the ones that go and leave the eyeball through the optic nerve. So when we're doing fundoscopy, the first layer we're technically looking at is actually a nerve fiber layer. But because the retina is transparent, we're not able to appreciate these layers when we are looking at the fundus. The fundus appears pink because of the blood vessels that are seen through the transparent retina. Not blood vessels per se, but because of the reflection of the blood through that. So rods are responsible for night or scotopic vision. The outer segment, they're called rods because the outer segment looks like a rod. It is a modified cilium specialized to absorb light. It is made up of stacks of about 1,000 membranous discs, which are studded with the globular proteins, the visual pigment rhodopsin. And then the inner segment contains organelles that are sitting on top of the cell body with the nucleus. And cones, the outer segment looks like a cone. The cones are responsible for our photopic vision or our daytime vision, and these are responsible for our color vision. And the structure is otherwise similar to a rod, except the outer segment is pointy, and the discs with pigment are plasma membrane infoldings, and they are not detached. Right. So this is again showing you a microscopic view of rods and cones. So these are the rods, and these green ones are the cones. And the outer segment of the rod looks like a rod, and the outer segment of the cone looks like a cone. And this is the end that synapses with the bipolar cells. So how does sensory transduction takes place in the retina? We have about 130 million rods. So we have the rods outnumber the cones. We have fewer cones in the retina. Only about 1.2 million nerve fibers in the optic nerve. So how come we have so many photoreceptors but fewer nerves? Clearly a very convergent pathway. Most of that convergence is taking place on the rods. There's very little convergence on the cones, and we'll talk about that in a minute. Right? Neuronal convergence and information processing in the retina begins before the signal reaches the brain. Multiple rods or cone cells will synapse on one bipolar cells. Multiple bipolar cells will synapse on one ganglionic cell. And this kind of convergence differs as we go from the fovea centralis to the periphery. All right. So this is just showing you a more general idea. Direction of light coming in from the vitreous body, going through all the layers of the retina, and finally getting absorbed with the pigment epithelium. As it goes through the layer of photoreceptors, it triggers the photoreceptors or stimulates the photoreceptors. They then activate or trigger the bipolar cells, which then activate the ganglionic cells, and the axons of the ganglionic cells are the ones that leave the eye as the optic nerve. We have a few other kind of cells. We have horizontal cells. We have amacrine cells. Again, these are all neuroglial cells. They help with things like sharpening the edges of our images, helping with contrast. So they play a role in making visual acuity better. Again, we're not going to go into a lot of details in this chapter. Your ganglion cells, this is a single layer of large neurons, the inner layer of the retina, and it is near the vitreous body. The axons form optic nerves. It is important clinically sometimes when, say, for diabetic retinopathy and hypertensive retinopathy, because of abnormalities in the blood vessels, certain things like lipids and other things can leak out of the blood vessels and collect in the layers of the retina. By the shape of collection of these things in the retina, you can determine in what layer they are. So because the layer with the ganglionic nerve fibers, the fibers are like little cords all parallel to each other. So any collection in those, between those fibers, will look like splinters. They'd be straight, short lines, so to speak. Anything deeper to that in between, say, your bipolar layers will be more cloudy and clumpy, right? So just from the shape of any material that collects in the retina, we can get an idea as to which layer these materials are leaking into, right? So some absorb light with the pigment melanopsin that is present within these ganglionic cells, and they send signals to the brainstem. So they detect light intensity for pupil control and circadian rhythms, but they do not contribute to visual image. Again, people who are otherwise blind, they too have circadian rhythm, and they too have all the other physiological changes seen in the body with, say, things like seasonal changes and with increase and decrease in daylight. Horizontal cells, amacrine cells, again, they do not form separate layers in the retina. They are connections between the cones and rods in the bipolar cells. So they help in enhancing the perception of contrast, making the edges of objects sharper. They help in detecting moving objects and changes in intensity of light. So much of the mass of the retina is actually astrocytes and other glial tissue. Pretty much like any other nervous tissue, your neurons are fewer. The glial tissue outnumbers the neurons, even though neurons are the one carrying out the job of passing, action potential. Visual pigments, the rods contain visual pigment known as rhodopsin or visual purple. Its peak absorption occurs at 500 nanometers, and it has two major parts of the molecule, the opsin, which is a protein embedded in the disc membrane of the rod's outer segment, and retinol, which is a vitamin A derivative. That's why vitamin A deficiency causes night blindness. Rods help us with our vision at night. If we don't have vitamin A, we don't make retinol. We don't make retinol, we can't see at night. So the most common cause of preventable blindness amongst children is actually vitamin A deficiency, night blindness, and of course, there are a few other conditions that come along with that. Cones contain photopsin, also known as idopsin. The retinol moiety is same as that of rods. The opsin moiety contains different amino acid sequence that determine wavelengths of light absorbed. So we have three types of cones. Each type expresses a different type of opsin. Therefore, it absorbs a slightly different wavelength of light. And brain then compares the response levels across all three different types to determine the entire spectrum of light, right? So each one gets stimulated to a different level. And with how much each one is stimulated, we're able to see all the different shades of colors. So that would be a rod with its discs in the outer segment. An enlarged view of the dish shows you the pigment molecule. And within this pigment molecule, we have opsin and retinol. And how this works is the retinol changes its shape in response to light. So normally you see retinol in the cis-retinol form. When it is exposed to light, it changes its shape and becomes straight. That's called the transretinol. This is the bleach retinol. And when it gets bleached, it separates from opsin. Right? So light changes your rhodopsin. In the dark, the retinol is bent. It is cis-retinol. And retinol and opsin are attached. They're together. In light, the retinal molecule straightens, becomes transretinol, and the retinol then dissociates from the opsin. And that's called bleaching. And it resets. So it takes time for this retinol to go back to its cis form. And that takes about 5 minutes to regenerate 50% of the bleach retinol. And this is responsible for our light and dark adaptations. We'll talk about that in a few minutes. Cones function similarly. The photopsin regenerates much faster, right? So the cones will regenerate, and regeneration means, are they ready for the next impulse? right? So cones get ready faster than rods do. And that property plays a key role in our light and dark adaptation, but that property also plays a role in sensitivity versus specificity, right? So in the dark, the retinal is in the cis formation. When stimulated with light, it becomes trans. And in this process, it triggers a second messenger pathway, which then triggers a signal to the optic nerve. And after doing that, the transretinal separates from the opsin, and then it regenerates, if you will. The transretinal is enzymatically converted back into cisretinal, and now it's ready to fire again. And how does it stimulate your ganglionic cells? So in dark, the rod releases glutamate. This glutamate inhibits the bipolar cells, and so they do not release any neurotransmitter, and so they do not stimulate the ganglionic cells. When stimulated by light, there is no glutamate secretion. If glutamate secretion stops, the inhibition of the bipolar cell ceases. And so now the bipolar cell is activated, it releases neurotransmitter, which then triggers a signal in the ganglionic cell. So what is light and dark adaptation? Light adaptation means you are adapting to light. That means from a dark room, you went into a bright area, like leaving the matinee show. After watching a matinee show, you step out into the bright sunlight. So we get blinded for a little while, but then after a little while, we're able to see properly, right? The pupils constrict. It reduces the light intensity coming into the eye and any discomfort that may accompany sudden brightness. Color vision and acuity will come back to normal within 5 to 10 minutes. This is the time needed for the pigment bleaching to adjust retinal sensitivity to the high light intensity. Rods quickly bleach and become non-functional, right? In bright light, the rods are bleached, they're non-functional, and only cones take over. Rods are extremely sensitive to light, but not specific, so to speak. Cones are less sensitive to light. That means you need more light to stimulate the cones, but they have really, really good visual acuity, and they can also do color vision. And so that's how we balance our visual acuity between sensitivity and specificity. Dark adaptation is the opposite, when we have to adapt to the dark. So when you first enter a movie theater, it's really, really dark and we can't see anything. We tend to stumble. But after sitting in the dark movie theater for a while, slowly we are able to start seeing things around us. And that is called dark adaptation, right? So this is in the dark where the rhodopsin of the rods is regenerated. So in about 1 to 2 minutes, the night or the scotopic vision begins to function. It takes about 20 to 30 minutes to the amount of regenerated rhodopsin is sufficient for eyes to reach their maximum sensitivity. And so this takes much longer. So we have that dual vision system, the duplicity theory of vision. Why do we have both rods and cones? We have 3 different types of cones. Again, a single type of receptor cannot produce both high sensitivity and high resolution, right? So that's why we have these 2. It takes one type of cell and neural circuit for sensitive night vision. You need it to be very sensitive. That means just a little bit of light will trigger vision. You will have some vision with just a little bit of light. So that's your sensitivity, and rods do that. But it takes a whole different cell type and neural circuit for high resolution. And that's your daytime vision, that's your cones. So during bright light, the rods are all bleached, they're not contributing to vision, but the threshold is higher to stimulate the cones, and we have 3 different types of cones, and how much each type gets stimulated gives us color vision, and the neural circuits we'll see in a minute are responsible for our visual acuity. So in scotopic vision, many rods are converging onto few bipolar cells, and several bipolar cells are converging onto a ganglion. This convergent circuit, what it does is makes everything very sensitive. So any one of these rods gets stimulated, this optic nerve fiber, this ganglion cell is going to get stimulated, right? So that increases your sensitivity. But there's no specificity. Once this ganglion cell is stimulated and sends an impulse to the brain doesn't know if it was this rod here that got stimulated or this rod here. So the light could be anywhere, the brain cannot discriminate, right? So visual acuity is not good. Visual sensitivity is really good, but acuity is not good. Whereas cones do the opposite. They have a private line to the brain, so to speak. And this is more in the fovea. As you move away from the fovea, so this is showing you like foveal neural circuit, and this is your peripheral neural circuit. So as you move away from the fovea, the neural circuit becomes more convergent, right? So at the fovea centralis, in the center of the fovea centralis, each cone stimulates one bipolar cell, which stimulates one ganglion cell, right? And therefore, we have more ganglion cells in the macula. And therefore, the area around the fovea is thicker because in the fovea, again, the retina is really, really thin because these cell bodies are also, they have pigment in them. They will obstruct light. So to keep the path of light as clear as possible, these layers are not there in the fovea centralis. In the fovea centralis, light goes straight and activates the cones. And their respective ganglion are around the fovea centralis. And therefore, the region immediately around the fovea is a little bit thicker because it has these cells that are connected to the cones right in the center. Then as you go further away from the fovea towards the rest of the macula, you've got these cones synapsing on the individual bipolar cells and individual ganglionic cells. But as you start going away from the macula towards the periphery of the retina, the number of cones decreases, the number of rods starts increasing, and your circuits become more convergent. So your visual acuity decreases, but your visual sensitivity increases. Rods are sensitive and they respond even to very dim light. There's an extensive neural convergence. 600 rods will converge onto one bipolar cells and many bipolar cells converge onto one ganglionic cell, right? So this results in a high degree of spatial summation. One ganglion cell receives information from 1 square millimeter of the retina, producing only a coarse image. So of course, visual acuity is not good. You can't tell which rod got stimulated in this whole 1 square millimeter of the retina. Edges of the retina have widely spaced rod cells that act as motion detectors. So we have good motion detection in the peripheral part of the retina as well, but it has low resolution. We don't have very good visual acuity there. It cannot resolve fine details of the image. So we can see in the dark, like we are very sensitive to light in the dark. We can see movement, we can see shadows, but we are not good with color vision. We are not good with details, with acuity. In light that is bright enough to activate cones for you to see clearly in color, rods are photo-bleached and therefore not contributing to vision. The fovea contains only about 4,000 tiny cone cells, no rod cells in the fovea. There's no neural convergence. So each foveal cone cell has a private line to the brain. And this results in high resolution and color vision. There's very little spatial summation happening and therefore less sensitive to dim light. So if the light does not stimulate a cone, that cone doesn't see, right? So the sensitivity is not there. We have 3 types of cones depending on what wavelength stimulates them. So we have short wavelength cones. Their peak sensitivity is 420 nanometers. We have medium wavelength cones and long wavelength cones. So we have trichromatic color vision. And any given wavelength of light will then activate all 3 cones at different levels. And so all that permutation combination is how we're able to see the entire spectrum of color vision, if you will. The color associated with the given wavelength is based on the pattern of activation across all 3 of these cones. So this is showing you your activation of the 3 colored cones and also your rods that are activated at 500 nanometers. So color vision, clinical aspect is your color blindness. It is a hereditary condition and where people lack one of the photopsin. It is most commonly seen as red-green color blindness. It results from lack of either the long or the medium wavelength cones. They have difficulty in distinguishing different shades of red and green. Again, there is a virtual lab on color blindness, and I highly encourage you to spend a few minutes going through that lab. It is a sex-linked recessive trait. It is on the X chromosome. And therefore, it is more common in males than in females because it is recessive and females have two X chromosomes. So if one X is carrying the color blindness gene, the other X is the dominant one. And so the female will not be colorblind even if she has one X chromosome that is carrying the colorblind gene. But in males, they only have one X chromosome. So if they get one X chromosome with the colorblindness gene, they don't have another dominant chromosome to dominate over it, and therefore they actually manifest colorblindness. Again, when we do genetics in AP2, we'll go into this a little more detail. So ACRS charts are developed to diagnose different kinds of color blindness. So the virtual lab that we have that whole thing. You can go through it and see the different kinds of color blindness in that. Moving on to stereoscopic vision, this is our ability of depth perception, right? So our ability to judge the distance of an object. Each eye has a slightly different visual field, but there's a huge overlap between the two visual fields, and that is important for depth perception. Unlike other animals who have panoramic vision, so they've got eyes on the sides of their head, so it increases their field of vision, so to speak. They have panoramic vision, but they don't have any overlap, and so they don't have good depth perception, and they are designed more to be alerted for predators. And again, there are certain animals who the two eyes move independent of each other. Like our eyes do not move independent of each other. When we're seeing or following objects in a distance, our eyeballs move parallel to each other, and then they converge when we want to see something close by. But the two eyes are always working together as a team, right? And the brain has been designed to see a single image. When the image of the object we're looking at falls on each eye's visual field is slightly different. So technically, there are two slightly different images formed. But the way our brain is designed to perceive it, we don't see it double vision, we only see it as one. But in certain animals, the two eyes can move independent of each other. So one is called like the roving eye that keeps an eye out for predators, and the other eye is the eye that they look for their own prey and for their food. We cannot do that. So fixation point, that is the point in space in which the eyes are focused. So looking at any object within about 100 feet, each eye views from a slightly different angle. So this provides the brain with information about the judgment of position of that object relative to the fixation point. Is it closer? Is it further? And again, those of you who are interested, there is a whole sort of a genre of art that you need to have good stereoscopic vision to be able to appreciate that art. I think they're called stereoscopic images. And people who have a blind eye or a lazy eye, or for any other reason they've lost their depth perception, they will not be able to see that art the way it is meant to be seen. So that's the fixation point. And so each eye is seeing the image falls in a slightly different place on the eye. And having the ability, the overlapping between the two fields helps us have depth perception. So we need binocular vision for depth perception. If one eye is closed, we lose depth perception. So visual projection pathway. So once the action potential goes to the ganglion cells up the optic nerve, we have an optic chiasm. So half the fibers actually cross over to the other side, right? So your retinal ganglion cell fibers, these are your second order neurons. The axons from the optic nerve exiting the back of the eye, half of these fibers from each optic nerve cross over to the other side. That's called hemidecussation, because the image of each side of the visual field falls on the opposite side. Remember when we did sensation, all the sensations from the right half of the body ultimately go to the left hemisphere. Similarly, all the visual stimuli from the right half of the visual field go to the left hemisphere, left occipital lobe. And the way we do that is, so if we are looking at the image of everything coming from the right half of our visual field, the image of the right half of the visual field is falling on the nasal fibers of the right eye and temporal fibers of the left eye. Therefore, those fibers must all go to the left occipital lobe, right? And we'll see that in a figure in a minute. So for that reason, we need half the fibers to cross over and not the other half. So fibers come together after the chiasm to form the right and left optic tracts. The right cerebral hemisphere sees objects in the left visual field because their images fall on the right half of each retina. Each side of the brain sees what is on side where it has motor control over the limbs. Optic tracts pass laterally across the hypothalamus, with most of the axons ending in the lateral geniculate nucleus of the thalamus. Remember, thalamus is your grand central station. It receives all sensory stimuli, right? So even the visual stimuli must relay in the thalamus. And finally, your third order neurons arising here and from the optic radiation of the fibers in the white matter of the cerebrum. They finally project to the visual cortex in the occipital lobe, where your conscious visual sensation occurs. So if there's any damage to the occipital lobe, it results in a condition called cortical blindness. It is sometimes seen as a postpartum complication. Few other cerebrovascular accidents and stuff can cause cortical blindness. So the eye is functioning fine. The optic nerve is functioning fine. Everything else is functioning fine. But the occipital lobe, that brain tissue, is damaged, and therefore it's not able to perceive. So that kind of blindness is called cortical blindness. A few optic nerve fibers will project to the midbrain and terminate in the superior colliculi and the pretectal nucleus. So we've seen the superior colliculus earlier too, right? So we have visual reflexes of your extrinsic eye muscles, and they coordinate, if you will, with your vestibule, the sensations coming in from the vestibule of the inner ear, right? So we talked about nystagmus as a consequence of labyrinthitis and stuff. So that's because of these connections. Your pretectal nuclei involved in your photopupillary and accommodation reflexes. Again, this is what makes the reflexes bilateral. So here, if you see the right eye, the visual field is the yellow, and the left eye, the visual field is in blue. And you can see this is your binocular field here. So this portion of the visual field is seen by both the eyes, and that's your fixation point. So what we're seeing here, if you were to divide the visual field into right half and left half, the nasal fibers of the right eye are getting the image from the right half of the visual field. The temporal fibers of the retina of the right eye are getting image from the nasal field of the right eye, right? And vice versa in the left eye. The nasal fibers of the left eye are getting images from the temporal field, and the temporal fibers of the retina are getting images from the right side. So therefore, half of these fibers cross over to the opposite. All the nasal fibers cross over. The temporal fibers stay on the same side. So as a result, the right side of the right occipital lobe is receiving sensations from the left side of the visual field, and the left occipital lobe is receiving sensations from the right side of the visual field. So some processes begin in the retina. Remember, the retina, the ganglion cells, is already a second order neuron, right? And we talked about the amacrine cells and the horizontal cells. So adjustments of contrast, brightness, motion, stereopsis, all of that is already started in the retina itself. Your primary visual cortex is connected by association tracts to the visual association area. So just like how we can map out the sensory and the motor cortex, the homunculates, similarly, on the occipital lobe, you can actually map out. And guess what? Because the fovea is the most central part, most sensitive part, with the best 2-point discrimination, that occupies a much larger part of the occipital lobe. Whereas the rest of the retina, which is much larger area, actually occupies lesser space on the occipital lobe. Again, because it had that convergent pathway. And so the occipital lobe is able to then identify the object location, motion, color, shape, boundaries, etc. This is all done in the association area as well. It stores your visual memory and recognizes printed words. And it's really, really interesting because printed word, it recognizes, but if you turn it around, flip it over, change it a little bit, we have difficulty. So our brain is really, really fine-tuned to how it recognizes printed words. And as I mentioned in class earlier, we have lots and lots of association pathways going from the occipital lobe to practically every other part of the brain. And that is about it. Thank you.